impacts if we actually know where the worms are and how best to target them. And this is where epidemiologists like Rachel come in. So Dr. Rachel Pullan heads up the London Applied Spatial Epidemiology Research Group, also known as LASER, who are based at the London School of Hygiene and Tropical Medicine. As part of LASER, Rachel heads up a group of epidemiologists who specialise in GIS, spatial analysis and field-based research, including large cluster randomised trials of public health interventions. LASER looks to work closely with national control programs and international agencies and places a strong emphasis on developing an evidence base that can be used to inform policy and practice. So with that, I'll hand over to Rachel and yeah, take away.
Okay, hello everyone. So that was an introduction to me. I'm an epidemiologist at the London School, as Franco says. Let me see whether I can move the slide on. Here we go. So today I'm just going to cover a few key areas. One of the first things I'm going to discuss is a bit of background and context, because I know everyone is probably very familiar with worms, but I'm just going to go through some of the basics. So when I start talking about different species, you'll know what I'm talking about. Then I'll just provide a bit of an introduction to global mapping of parasitic diseases and go into a bit more detail about how we map worms. And then there's just a final elephant in the room that I'd like to discuss. So I just want to start out, and some of this may well be revision or very familiar with to many of you, but I think it's always helpful to know what I'm talking about when I talk about worm infections. So many parasitic worms can infect humans, and they can be found in the intestinal tract, in the urinary tract, or in the bloodstream. The most common ones are the nematodes, so soil-transmitted helminths, or STH, and these are the ones I'm going to be talking about the most, and also schistosomes, which are responsible for schistosomiasis or bilharzia. And there's also another group of worms known as the filarial worms, and these cause LF, onchocerciasis, and also guinea worm. Now, the worms that we're going to be talking about today are the STH and schistosomes. So although a lot of our work also focuses on filarial worms, I won't be talking about those today because they don't affect children so badly. The infection is we typically know when someone is infected not by seeing the worms, but by looking for eggs in stool samples. So this is a typical example here of a roundworm or ascaris in this photo here, and this is just the worm burdens from one child. But I just want to provide an introduction here for the STH, so soil-transmitted helminths. Now, there's a number of different species that people can be infected by. Children can be infected by roundworm, which is Ascaris lumbricoides, whipworm, also known as Trichuris trichuria, and there are two different species of hookworms. So in many parts of the world, hookworm predominates, and so that's particularly the case in a lot of Africa, whereas in Asia, roundworm and whipworm are also more common. And in the Americas, whipworm is surprisingly common. All of these infections can delay growth, learning and education, as Franco said. It's very rare that they would result in death or any really severe morbidity. But because of this, because it goes unnoticed for a really long time, people can develop very high intensities of infection, and it's very high intensity infections that cause the most symptoms. And it can lead to malnutrition, growth retardation. It's also a problem during pregnancy, so it can be quite an issue for adolescent girls because heavy infections with hookworms can lead to anemia. Another one that I'm going to talk about is schisto. So schistosomiasis, there are two major forms. There's genitourinary schistosomiasis, which is caused by Schistosoma hematobium, and that's where the eggs go to the bladder. And then there's another form, intestinal schisto, where again the worms live in your blood vessels, but the eggs go to your intestine. And the major type is Schistosoma mannsoni, although you may hear mention people talking about S. japonicum, but that's much rarer and it's only found in Asia. It's the eggs from these worms that cause all the morbidity, and that's because when they get trapped in places like the intestine and the bladder or the liver, they cause fibrosis because your body responds to them and you get an immune reaction to the eggs. and it's that causes the major symptoms. So it's not actually the worms themselves that are causing problems. So for urinary or genitourinary schistosomiasis, this can cause bladder wall disease, leading to all sorts of pain and things when urinating, and red urine. So the key feature when you, if you go into a school where urinary schistosomiasis is a problem, and you ask people, they'll know if they're infected because they have red wee. In intestinal schisto, things are a little different. There, the eggs go to the intestine, and but on their way there, they can cause a lot of damage in the liver and spleen. Schistos also can cause chronic growth faltering, and that's because of the anemia of inflammation. So that's the fact that you're infected and you've got this chronic inflammation. That in itself can lead to anemia and can be quite a big problem in children. So just to provide you a bit of background on how they're spread, everyone knows they're associated with poverty and inadequate sanitation and hygiene. That's because for Ascaris and Trichuris, so whipworm and roundworm, you become infected by eating or drinking food or drink contaminated with eggs from feces. So if you had the eggs on your hands or in your food, that's how you become infected. For hookworm, there's an additional stage because the eggs have to hatch in the soil and develop into small larvae, and then it's coming into contact with those larvae where you can become infected, and that can be through the skin. Right. Schisto is a little more complex because part of the life cycle involves freshwater snails. So you only become infected with schisto if you come into contact with water where the infective stage of the schistosomiasis parasite is, and that is because it's passed through a snail and released into the water. So unlike STH, where we can think transmission might actually happen within the school, schisto isn't going to be transmitted within schools because unless there's water bodies at the school that kids are playing in, it's more likely that transmission will happen as kids are playing in the evenings or collecting water in the mornings. Just to give you some estimates of burden, so these numbers are coming from the most recent Global Burden of Disease study, which is for 2013. And just to restrict it to school-age children, there's an estimated 0.4 billion children under 15 who will be infected with at least one STH species. The most important of these is actually roundworm. And this is because roundworm is most prevalent in school-age children and is prevalent in areas like such as Asia, where there are large numbers of children. So globally, it becomes the most important infection. And it's actually a particular concern in sub-Saharan Africa for preschool children. And that's because those that do have high-intensity infections are at risk of wasting. The numbers associated with schistosomiasis are a little more uncertain, but in general it's thought that there's around 770 million school-age children at risk of schisto or affected by schisto, and this contributes nearly 400 DALYs per 100,000 people, and this is nearly all in sub-Saharan Africa. So this is the first map, just to show you the general global distribution of STH, and you can see it's very widespread. So all of those areas that are stained dark green are within the stable limits of at least one species of STH. So if you're living in a poor rural community, in anywhere here shaded green, you are likely at risk of at least one species of Helminth. However, the numbers are declining, so this may be due in part to improvements in living standards, improvements in sanitation and hygiene. However, it's also quite likely that the very large school-based deworming programs that are ramping up at the moment are having a large impact. And some crude estimates suggest that at least the number of children living with worm infections was possibly cut in half in the last 5 years, which is really impressive. So just to give you a little bit of background around the politics and what's happening at the moment in STH control, there's been a huge ramp up of commitment to NTD control in recent years, with a lot of periodic deworming campaigns with safe, cheap drugs. And this has been driven by some really major commitments made by large global partners. So this was triggered in January 2012 by the World Health Organization roadmap for the control of NTDs. And this is a document that leads out the WHO's vision for control, elimination and eradication of a group of diseases called the NTDs, or neglected tropical diseases, and this includes worms, and it includes several other diseases associated with poverty, often parasitic diseases, and it included local, regional and global aims for either elimination or control by 2020. At the same time, this triggered a large group of global health organisations, donors and the drugs companies to endorse the London Declaration on NTDs, which was a declaration around ensuring that we have the tools and the resources to achieve the WHO roadmap. And one of the most important things around this is the donations. So the pharmaceutical companies all signed on to donate sufficient drugs to allow us to reach these target goals. And as a result of this, NTD endemic countries have developed multi-year plans and have begun to allocate resources to NTD control. And this was supported in May 2013 by a WHO resolution on all 17 NTDs. So you can see there's a lot of global advocacy behind NTDs, and there's a lot of movement towards control of these infections. So this is some of the policies behind the world of NTDs at the moment. So as I say, STH can be, and worms can be controlled effectively with these cheap single-dose drugs. They should be ideally provided, so they're provided through mass drug administration, and that is because it's expensive and difficult to see who's actually infected. Instead, what we'll do is we'll just treat everybody who lives in an area at risk, because the drugs are cheap, they're safe, and we only need to treat them once to clear infection. Now, that doesn't stop them from becoming reinfected, and this is why treatment should ideally be implemented alongside improvements in sanitation and health education. However, even though this reinfection can occur, the risk of developing any kind of severe disease is diminished, because remember I was saying severe disease is associated with high intensity chronic infections. So if we keep clearing infections, even if people are becoming reinfected, the impact of those infections is going to be much less. So for the worm diseases that we're talking about, STH and Schisto, the WHO has identified key groups for this mass treatment, and two of these are important to people listening to this seminar. One is school-aged children, and also preschool children and pregnant women. However, in communities where infection is particularly common, and this is particularly the case for schistosomiasis, all individuals at risk should be offered treatment. So, moving on now to school-based deworming. So as I've said, school children, or school-aged and preschool-aged children, are the WHO mandated group that require deworming treatment. And this is because school-aged children typically have the highest intensities of worm infections in any age group. And as I remember, I said this is especially true for Ascaris. And deworming can really improve kids' health, but also their growth, and benefit their learning by increasing primary school attendance. School-based deworming is perhaps the most cost-effective way to deliver deworming regularly to children as well, because you have readily available, extensive sustained infrastructure close to communities. It's much easier and quicker to implement a training cascade through schools to teachers who can then give out pills in the classroom over the course of a single day. So it's a very cost-effective way of delivering mass treatment to all school-going children. And this is just a graph to emphasise the importance of school age. And you can see there's quite a difference here between the blue line and the green line show roundworm and whipworm. And you can see that these really peak in school-aged children. So if we were to treat school-aged children, we would see a big impact on worm burden in communities. Now, hookworm is a little different because that keeps rising. So this is the the distribution that you would expect to see if a population, a community, had had no treatment for hookworm. And here it just keeps rising and rising. So it's actually in the late 20s that we really see it level out. However, if we treat a lot of the school-age children, then you're going to see a big impact here on the levels of transmission and on the levels in this kind of age group, which will pull down that line. So treating school-age children is going to have a big impact on transmission in communities. So the control strategy, which focuses on MDA, we know that we need to treat school-age children that require treating. And this need for MDA is determined by... Oh, my presentation has disappeared. Hello? Hello, everyone.
Rachel, I can take over for now. One thing.
So it's low. Sorry, my presentation disappeared. It said I was having network issues, and now it's come back. Did you hear all of that? Were you able to?
Yeah, we can hear you. You can go ahead and continue.
Okay, so I'm back on geotargeting now. So one of the so MDA is the need for MDA is determined by infection prevalence. And to determine infection prevalence, we need to map the disease. So we need to know where it is to know where to target MDA. And that's where some of the main bulk of this presentation is going to be focused on. So these are what I've presented here are the WHO guidelines on who requires treatment for STH and for schistone. So in areas where STH is common, the WHO recommend that if prevalence is higher than 50%, treatment should be targeted to all school-aged children twice every year. So in very high, and there's very few bits of the world now that really have prevalence of infection this high in large areas. But in those areas where it is this high, and the WHO recommend that we treat all school-aged children twice a year. However, if it's between 20 and 50, they recommend that we treat once a year. The frequency of treatment for schisto is a little lower. So when prevalence of schisto is greater than 50%, because of things like reinfection rates and drug availability, it's recommended that we treat once a year when prevalence is greater than 50%. If it's between 10 and 50, we treat every 2 years. And if it's lower than 10, but still transmission is occurring in that community, it's recommended that schools treat children twice, once when they enter and once when they leave. So these are the thresholds and the recommended targets at the moment. They're constantly under scrutiny. So what we really need to know is which areas have prevalence of these levels. What we do have, and we don't need to worry so much about, is the drugs to do these treatments. So this is just a press release from GSK that was released shortly before the London Declaration. And this is when WHO pledged to provide sufficient albendazole, which is the main deworming drug used for STH, to treat all children that need it. So we don't need to worry about whether we've got enough drugs, we just need to worry about whether it's getting to the children that need it. And this is just to show you where we're at the moment. And this shows the estimated coverage of preschool and school-aged children. So the school-aged children in red and the preschool in blue from the year 2000 onwards. And you can see there's been a real sort of scaling up, particularly with preschool children. And preschool children are treated generally through either a school-based deworming program that also invites preschool children into schools, or more generally through combined child health days run out of health centres. And you can see there's been a real... Hello?
Hi, really quickly, your slides aren't moving forward. Are you hitting the next button?
I am, yeah. Are they not moving?
No. What slide are you on right now?
Okay, I'm sorry. Here we go. Let's see. Because it kicked me off the presentation. I think it didn't... let me see now. Sorry about that. It's just loading.
There we go.
There we go. So this...
Thank you.
So let me show you. You didn't really miss anything, slide-wise. There we go. So, oops, it was just that press release. There we go. So this is a graph showing coverage against year, so the amount of children who require treatment who are actually receiving treatment, and you can see that it's scaling up every year. However, to actually achieve the levels that we need, this rate of scale up really needs to increase. And this is showing the levelling off here is the proportion, the numbers of school children that we think require treatment at the moment to reach the goals in the WHO roadmap, and that is that 75% of children that require treatment are receiving treatment by 2020. So I'm just going to, now that I've provided a bit of background into why we want to treat school children, why we're treating them through schools, and how many we need to treat, I just now want to talk a bit about global mapping of parasitic diseases and mapping of STH and Schisto in particular. So we've been mapping, there have been scientists looking at mapping the distribution of helminths for a long time. So this shows one of the first Helminth distribution maps, and this is from Texas, so the southern states of America. And one of the first sort of issues that the Rockefeller Institute actually looked at was Helminth infections, because they were common in poorer communities, because the environment in the south of the states is perfect for helminths. It's warm and green. So you can see here, this is one of the first maps of hookworm in Texas, and some scientists more recently reproduced some of this work, looking through some of the older data that was collected around the same time in 1910, and remapped this to show the distribution of hookworm. And you can see that there are areas in the southern states of America at the turn of the last century that really had a hookworm problem. But one of the first people to actually consider mapping worms on a much larger scale was Norman Stoll, and he published his seminal map of the distribution of worms, and this is where our own website, This Wormy World, gets its name, in 1947. And this is an updated version of that very map, and you can see it's very beautiful, and it shows the expected distribution of a number of different types of worms. So helminths is just a fancy name for worms. And so you can see in the top left, it shows the distribution of Schistocytes. But there's a number here, so it was a huge effort, and this was all done pre-internet. And it's an incredible effort. But if we look to the maps that were available more recently, this shows the WHO's global STH map for 2010. And you can see here, this reflected very much the distribution map I showed at the beginning of the talk. And you can see that there's, you can see the areas that are suitable for STH and less suitable. But if you were designing a control program, this isn't really that helpful, because it just shows the status of an entire country. And we know that the prevalence of STH varies considerably within countries. So if we want to target our program, we need higher resolution maps. And this is where the Global Atlas of Helminth Infection comes in. So this online resource or online website intends to provide resources and tools for mapping of NTDs. So mapping of a number of different worm infections, and that includes the STH and Schisto that we're talking about today. This just shows you what the front page of our website looks like at the moment. So we provide a lot of maps of the distribution of worms, but we also have training, and we do a lot of research. So I'll go into some of the maps and then talk a little bit about some of our research and our training. So the overall goal of the atlas was, or of the project, was to develop an open access global information resource and additional tools for NTD control. We wanted to collate into a single database all available information on the prevalence of STH, Schisto, and also lymphatic filariasis, which causes elephantiasis. And we want to use this data to describe the distribution of these infections. And the reason we wanted to do this was to provide an information resource to guide control efforts. And this was our primary aim, was that we were able to develop maps that allow implementers of control programs to know where they need to treat first to have the largest impact. We also, we're research scientists, so we conduct research onto the spatial epidemiology of NTDs to try and understand why they're distributed in the way they are. And we also develop training resources and mapping tools, which I'll talk about in a bit. So the first thing I want to do is just go through the process that we use to develop the database. We conduct a series of systematic searches, and we reproduce these every year or so, and we search through all electronic bibliographic databases. So we look through all the published literature. We also look through local archives and libraries. So we've often visited countries to spend time going through local archives, research institutes and things, to find data that hasn't made it into the larger databases. We also directly contact researchers. We work with the WHO particularly to try and ensure that as much of the most recent mapping data that is available and that authors are happy to share with us becomes available through our map list. We then abstract key information from each of those surveys. We have very strict inclusion and exclusion criteria, so we only include representative data from the populations where they're taken. So they have to be from community or school-based random surveys. We don't take data, say, from clinics or from health centres, because we don't want to know what's happening in the sick people. We want to know what's happening. We want it to be representative of everyone that's living there. We abstract the source of the data, the location of the survey, and information on how the survey was conducted, as well as the numbers sampled and the numbers positive for each species. We position that. So more frequently now, when people publish their surveys or make their surveys available, they've collected the data using, say, smartphones or other technologies, which means that they have the latitude and longitude available straight away. That wasn't always the case, and so a lot of older survey data, we've had to go onto gazetters and online maps to locate the location of every single survey, and we try and get a survey located to a single point. And this means that if district boundaries change, we still know which district that school is in, and so we know where that information applies to. And all these features of these data that we abstract, we make open access. So if authors are willing to share the data and happy for us to make it open access, you can go onto the website and you can download this data. So you can access the data sets for whichever country you're interested in. This is one example I'd like to show you. This shows the empirical data that we have on schisto for sub-Saharan Africa. So as I said, remember there's two main species of schisto in sub-Saharan Africa. We've got intestinal, or S. mansoni, and urinary, or hematobium. And you can see here that they are distributed. So there's all the areas where schisto is common have generally been pretty extensively surveyed, and that is because schisto is very focal, so it's very difficult to know from one school to the next whether schisto is going to be present. Here you can see on the right hand side the distribution of each of these species, and you can see in East Africa a really clear trend going northwest to southeast, moving from mansoni endemic area to a hematobium endemic area, with an area where co-infection happens. In West Africa, this picture is much more mixed. We don't just present point data, however, we also use this data to help us predict the prevalence of the distribution of disease in areas where we have no survey data. So these two maps here show the predicted prevalence of Ascaris and Trichuris, so that's roundworm and whipworm, across the whole of sub-Saharan Africa. You can see there's areas in the north, so the Sahara, where it's very hot and dry, and then down in Namibia, again, where it's very dry, where it's unlikely that STH can be transmitted because it's just too arid. But however, throughout the rest of the continent, we predict a range in prevalence from 1% or lower up to in excess of 50%. And particularly noticeable here is Trichuris, so that's the map on the right-hand side. Along the coast of southern Africa, we see quite high predicted levels. A lot of this is because many of these areas haven't been mapped recently, and historical data suggests very high prevalence of these infections. So they may not necessarily reflect the situation today. So you can see this is a useful tool for designing where we might want to think about doing surveys where we don't have data. And this map here just shows the combined predicted prevalence of STH. So this is the predicted prevalence of any species. And you can see that the areas that are particularly at risk of STH and really require concerted effort for treatment are the sort of central Africa, as well as regions in southern Africa. The next example I want to take is just where is just to walk through an example of where mapping approaches like this have proved vital for the planning of control programs. And the one that I'm going to use as an example is the STH control program in Kenya. So back in 2001, the WHO endorsed a resolution to control STH and set a target that we need to be treating 75% of school-aged children. This is the target we're still aiming for, and as you could see from that graph, we're still quite a long way from there. However, in 2009, the government of Kenya launched the School-Based Deworming program, and in the first year treated over 3.6 million children in Kenya. And there was a little bit of a break after that, but by 2011, Kenya had launched the NTD strategic plan, which included school-based deworming. And from 2012 onwards until this year, the Ministries of Health and Education have worked together to deworm all school-aged children who live in areas designated as high STH prevalence. So the first thing we had to do was identify where those areas are, and this map here shows the survey data available to inform our decision. This shows both historic and more recent data, and the distribution of survey points, so the dots actually reflects the distribution of the population of Kenya. So the majority of people in Kenya live either along the coast, in the central region, or over by the lake. The area that's mapped out in red is very dry and arid and isn't suitable for transmission, so we don't need to predict what's happening in those areas. However, we use predictive models which take information from nearby surveys and also from environmental factors to predict the distribution in the rest of Kenya, and the areas shown in blue here are predicted to have low prevalence of infection and so won't require treatment. Those in yellow to red are predicted to have either medium or high intensity infections, so require either once or twice yearly annual treatment. So these maps were used to guide the programme, and as you can see, let me go back. There are two areas where we really require treatment, on the coast and then over there in Western Kenya. And so when the programme started in 2012 to formally deworming every year, there was a concerted effort to develop a careful monitoring and evaluation plan to see what was really going on with these programs and ensure that we were treating children effectively. So this data shown here, these maps here show the distribution of prevalence at baseline. So each of these points is a school that was selected to be an M&E school within that district, and you can see that prevalence varied within these areas. Ascaris was much more common. So Ascaris is roundworm, remember. There's no trichuris in Kenya. There are pockets of trichuris in Kenya. It's not as common. Over by the lake in the west, you can see that there's a lot of Ascaris. However, there isn't much on the coast. Hookworm is more widely distributed across both sites. These schools were monitored over 2 years, so looking at the first 2 years of the programme, we looked at the overall change in prevalence across these schools. And so the one on the graph on the left shows the number of children that were infected, and the graph on the right shows the average intensity of those infections. And these graphs show a mixed picture for the impact of the school programme over this first 2 years. So Ascaris, as you can remember, that's roundworm. We saw a small or a moderate drop-off in prevalence, but very little change in intensity of infection. Hookworm, we see a very large drop in prevalence and a reasonable drop in intensity. And then Trichuris, the changes in prevalence and intensity are much more modest. Now, this was a little surprising at first, but I think one of the main reasons for this is because treatment is once a year, whereas Ascaris, actually the reinfection rates are very quick. So if you go back 9 months to 12 months after you've treated, you will find a lot of your children have become reinfected. However, hookworm, the reinfection rates are much slower. So if you treat once a year in an area which is predominantly hookworm, if you look just in school-aged children, you will find that your annual treatment has a big impact on the rates and intensities of infections in those children. So this shows you a little bit how the species that predominate should be helping to inform us what strategy we take to deworm. If we want to look at this from a more spatial point, we can also map the difference in prevalence and intensity. So these maps here show the relative reduction. So those areas that are shaded green show a very big reduction, and those areas shaded orange show a very small reduction in prevalence at the top and intensity at the bottom. So intensity, remember, is a more direct indicator for morbidity. So what we really want to see are big differences in intensity. And this can show us, taking a spatial aspect to this and looking at it through these maps can help us really see where the programs have been most effective and had shown the biggest reduction, and where they've been least effective. So taking an example, hookworm, which is the two maps on the right-hand side, if we look at the bottom map, you can see that there's, to the south of the lake, there's a large district where we're actually seeing a small relative increase rather than decrease in the intensity of hookworm infections in this area, which suggests that our program is least effective in this area, and it might be we may have to look into the process of conducting the deworming in this area to ensure that the systems are all in place adequately. Okay, I want to just jump now to something slightly different, and this is just to show you a tool that we have developed to allow you to make your own maps for the countries that you work in. So the data included on this mapping tool, and this is located at a different site, so it's not at this Wormy World, which is the Gahi site, but is instead hosted at ntdmap.org. This contains our data from Gahi, but it also contains data from other programs. So ITI is the International Trachoma Initiative. APOC was the body that oversaw the onchocerciasis control program. So these are two other NTDs, programs that sit behind other NTDs. And all of our data is co-hosted on this one platform that allows you to make all the maps that you might need to help make decisions for your country. So this just shows a close-in here of Uganda, showing the prevalence of schistosomiasis around Lake Victoria. So here you can zoom in on the area you're interested in, switch on so on the left-hand side here is a live legend, and you can turn things on and off. So you can say, I'd like to see schistosomiasis plotted as points. I want to see country boundaries. These are all ticked on and off. So you can choose to make the map exactly of the area you want and turning on the layers that you want. Here is a border scale map for the whole of a bunch of Africa, showing also water and sanitation. So we've predicted the access to potable water and to adequate sanitation across the whole of Africa using population-based surveys. And here you can overlay where STH is highest and where access to water is lowest. Regardless of your actual skills of using mapping software, you can produce your own maps using this website. Then you can download the maps, you can print them, you can send them to yourself by email. The data is all open access, so if you're interested in downloading either the epidemiological data or the geographical data, you can download it and you can analyse it however you want. But if you're more interested in making maps for yourself, I'd just like to flag up a short course that we offer This course we have physically taught it in 3 locations, so we've it's a couple more than this now actually, but we've taught in Nairobi, in Addis, and in Nigeria. We've also, we're going to be teaching it later this month again in Addis, but this course teaches the basics of a package called Quantum GIS. This is a free open source software, so you can just download it from the internet for free, install it on your computer, and then if you go to our website, all of the training resources required to teach yourself how to make maps are there. So we offer this as a course, but you can also download the course material yourself to learn how to make maps yourself. So then you can get your own data and make maps from that data. The last thing I just want to mention, and I put a couple of slides in about this because I feel that people may have questions on this, and that is the sort of elephant in the room that comes up now whenever we talk about deworming, and that is some of the recent worm wars that have been raging. And I'm not going to say too much about this, but I'd just like to acknowledge it. So, and this is what the big elephant in the room that I hinted to before is. So the WHO is recommending MDA for vulnerable groups. So that's children and pregnant women who live in areas where we see worm infections. However, a lot of recent systematic reviews have argued that there isn't sufficient evidence that it produces health benefits. And so these reviews don't support the use of MDA. So I'd just like to give one sort of viewpoint on this. There's a couple of arguments I'd like to make for deworming. The first is that there's a substantial literature, historical literature mainly, describing the clinical consequences of infection. So we know from clinical trials, from observation data, that patients who have worm infections, when treated, see benefits, and that the worm infections cause them harm. So we know that treating someone who has worms is good for them. The current strategy of mass drug administration makes trial design quite difficult because you can't identify who is infected with worms before you do your treatment, because you would have to treat everybody. So even if there was a considerable benefit for those minority individuals who are intensely infected, once we look at population effects, you'll see little or no benefit to those with either no infections or light infections. So the difference between your arms receiving MDA and your arms not receiving MDA is very minor. So I just wanted to acknowledge that. That's my argument for deworming, is that MDA is the most cost-effective way of ensuring those people that need treatment receive treatment. I think that's the end of my presentation. I'm afraid I don't have an acknowledgement slide. So
Great, thanks very much for that, Rachel. That was really informative. There's a number of questions which have come up as you've been presenting. And first one, if you click on the, can you see a speech bubble, instant messenger, or speech bubble on the bottom left-hand corner? You can click on those, or I can just read them out to you. So the first one is actually looking at data. There's a couple of them about data. One is it mandatory for countries to report on worm infections at WHO, and if so, how is this collected?
Sorry, come again.
So in terms of collecting data from countries, do countries have to provide WHO with data, or how is this data collected? How do you get data in? Okay,
so there's now a big scaling up of national mapping to inform programs as programs have been expanding. So if we take Africa as an example, there's currently a very large WHO-run project to improve mapping of, to fill in the gaps, to ensure that we have mapping data, we as a global community have mapping data for the whole of Africa for worms and for other NTDs. And this is overseen by the WHO and by national control programs. The national control programs then own that data, and they can make treatment decisions based on that data. They will often share summaries of that data, and they're sharing that data with the WHO. However, it's their own data, so if we know that there's been mapping activities going on, we'll often speak with the program managers and see if they would like to share the data with us. But it is their data, so it's up to them whether they want to share it. A lot of the data that we have that's separate to the data that WHO have are research studies. So you may have very large research studies that have conducted surveys across areas of countries, but perhaps not national surveys, and that data might not be available if you just go to WHO platforms. So this provides an alternative source of data as well.
Okay, and actually you mentioned about school surveys, and Doug asked a question of if this data is collected through these school surveys, do these surveys report on more than one ID? Doug, what do you mean by ID?
Infectious disease?
Oh,
yes.
Well done.
Yeah, so because they are, so most school surveys, they're stool surveys, and in general the stool samples are read on that day. You just make up a slide and you look for eggs in the slide. So quite often surveys will be looking for SDH and schistosoma at the same time, but other infections that require different diagnostics, there's the cost-benefit ratio. So most school surveys will just include STH and schisto. They may also include, so I have seen examples, particularly in Kenya, of integrated mapping with malaria. So they may also take blood spots and look for malaria. It's a nice platform, these school surveys, to collect a lot of information. So it has been used, but not commonly. It's normally just STH and schisto.
Okay, and on slide 30, you showed a map of Africa and the prevalence of Ascaris and Trichuris. But you mentioned that there was no previous, there was very little data previously on South Africa. Why was that? Mm-hmm. Why was there no prediction for South Africa?
I think that it's partly, so we masked out the predictions for South Africa because it's based on very old data, but it's been a lower priority in South Africa. So there is now an effort, as I said, there's this effort to fill in all the mapping gaps, and so there is now a strategy to map South Africa, but it's still ongoing, so it remains one of our final gaps, and it's because it's had a lower priority within the Ministry of Health there.
Okay, and that much showed Ascaris and Trichuris. Do you do predictive prevalence maps for STH as well?
Do we have predicted prevalence maps for STH?
Yeah.
Yes. Yes. So they were the predicted prevalence maps. Do you mean for schisto?
Sorry, for schisto. Yeah.
Yeah. So schisto is much harder to predict, particularly on continental scales. So there have been researchers have published continental maps, say, for schisto. However, schisto is very, very focal. It depends on the water bodies in that particular area, and so it's much harder to produce reliable maps over large areas. And in general, most control programs use a much more intense mapping process like LQAS, lot quality assurance sampling, where you just want to determine whether all your schools in an area are above a certain threshold, so you map every single school in that area, and that's often the approach taken for schisto. So we don't have large predictive maps for schisto that are very reliable.
I've got a couple of questions from Mahini about and this actually maybe comes to one of the cruxes of this, is how prevalence mapping really impacts on programmatic design. So she asked a question: did the relatively less reduction in Ascaris prevalence lead to a change in the frequency of deworming to twice yearly in Kenya? So if you saw a change in the level of prevalence, has that had an impact on program design in Kenya?
Unfortunately not, and that's because the program in Kenya is it's funded for 5 years, and they only have the funding available to treat once a year. However, we do actually have a large research study going on in Kenya at the moment, in coastal Kenya, looking at the impact of treating whole communities twice a year, and that's called Tumikia Project. And if you're interested, it's on the web. You can look up details on the website. But that study will hopefully will be finishing next year. It's a 3-year study that will provide a more definitive answer as to whether we might be better off treating twice a year to have a big impact on worm infections.
Okay, and the second question from me is, do you also overlay deworming prevalence data with deworming coverage data to predict future prevalence?
So this is something that we're working on at the moment. So there's a large research consortium called the NTD Modelling Consortium, and this is a Gates-funded initiative which brings together infectious disease modelers. So it's modelers that predict what's happening in the future. And they predict actual transmission. That overlay. There's a large group of those, the NTD Modelling Consortium, and we are currently working with them to help link their predictive models to our risk maps. And so there's a tool that we're in development with at the moment that we will be launching towards the end of the year that looks at linking our predictive risk maps with the transmission risk models and the coverage data to give a real sort of to make a really informative tool around the amount of treatment that will be required to address that future prevalence question.
Okay, thanks very much. The next question is from Doug, and he asks, is there a global network of so I've just lost it. Is there a global network of researchers on infectious disease data research relating to school-aged children, like the HBSC on child health behaviours? So is there a coordinating body to collect all this data and research together on school-aged children?
No. So there are various different initiatives around school-aged health, but to my knowledge there isn't a single database that collects together data on other aspects. So there are the various atlases, so the STH atlas and similar, but I'm not aware of one platform that brings together all the different types of data that might be collected.
Okay, and question from Vidya. Can you please elaborate on the M&E tools used while assessing the impact of school-based deworming program in Kenya, and if possible share with us any information?
So this program, the design of the M&E platform included recruiting a large number of schools that were monitored pre and post treatment for the duration of the Kenya program. So that's been going on for 4 years now, and perhaps the best thing I could do is point. So there have been a number of publications around this, and I can after the webinar I can paste in some of those publications which explain the design of the M&E program and then the findings of the M&E program at baseline and after 2 years. So that might be that might be the most helpful thing I can do, and that will provide you with a comprehensive overview of that program.
Great. We'll share that with the wider group. A quick question for me: Can spatial epidemiology be used beyond NTDs in terms of school health? So we've talked about NTDs here. Can this technology be used elsewhere?
Yes. Well, so epidemiology is concerned with time, place, and person. So spatial epidemiology is a fundamental component of understanding the distribution of diseases. So there are. It is a widely explored platform for NTDs because these are diseases associated with the environment. So there are obvious spatial components to those diseases. However, there's a lot of downstream effects of these NTDs which can also be looked at through a sort of spatial viewpoint. So that includes things like anemia. And so one thing that we have done is looked at the spatially varying impact of different factors on anemia, and this was again in kids in Kenya, looking at in different areas what are the most important causes of anemia within those school children. So we can look at those downstream impacts. We can also use the same approaches, so the same ways of looking at the data, to look at other factors such as access to water and sanitation, say. So understanding the spatial distribution of access to various features like that.
Great, thank you. Well, we're about 2 o'clock. Is there any other questions that people would like to ask? And if not, I'd like to say thanks very much for that, Rachel. It's really informative, and we'll be sharing. We'll be posting the recording of this on online in the next couple coming days, and we can share even any other information as and when.
Okay, thank you.
Franco, just very quickly, sorry to interrupt, but I just didn't want to leave that brief discussion of the systematic review. I'm not a researcher, but...
Oh, sorry, Doug, we've lost you.
Try again. Can you hear me now?
Yep.
Yes.
Just quickly, that systematic review, the debate's been quite extensive, and I'm going to try to post a link to the group. We've tracked down most of the recent discussion of that, and I think the systematic review is as they have to be, is very narrow. I think it really expects one treatment of a pill to have significant impacts when that's not really fair. So I think there's more to it than just that systematic review, and maybe that's something we could in the next part of the series come back to, those kinds of reviews, because it really was not fair to try to expect one administration of a treatment to have an impact on nutrition and school attendance and all those other things. It's just not feasible for one specific intervention to be expected to do that, in my view, anyway.
Okay, thanks so much for that, Doug. Rachel, do you have a response?
Only to say, no, I fully agree. I think the problem is that those systematic approaches to evaluating evidence aren't necessarily the most helpful for large public health interventions, and so it's a bit black and white. But I think that the only way that you can help address some of the concerns are to address them rather than just argue about them. So I think some of the published literature in response to that is very helpful. So I think that's if you've been assembling that, then that's probably a very useful resource to help people come up with their own interpretation.
Great. All right. Thanks very much for that, Rachel. Rachel, is it all right if people have further questions to contact you directly? So to put you on the spot a little bit. Just drop you an email. Would that be all right?
Yes, of course. Yes, please do.
So I'll forward Rachel's email around the group for those who'd like to follow up with any queries they may have. Okay, well, thanks everyone. And next month's webinar will be on the impact of nutrition in school feeding in Ghana, and will happen on the 15th of next month, September. So please look out for details. In the meantime, thanks again, Rachel, for that. That was really informative.
Thank you. Bye.
Okay, bye everyone.
Thank you. Thank you. Bye-bye.
Bye-bye.